image quiz in the New England Journal involves a 42-year-old man who was undergoing treatment for Hodgkin's lymphoma, and he's had several courses of chemotherapy, and he complains about these fingernails. These are Mees lines, or Mees bands, and they are a nonspecific finding of acute episodes of some sort of chronic problem. And the only one of these five possibilities here that fits this scenario is cancer chemotherapy, which certainly can cause Mees lines. Now, what bothers me about this picture are these brown fingernails, because I'm not familiar with chemotherapy making fingernails brown. The hand is also fairly brown, and I'm not quite sure what's going on here. Obviously, the fingernails weren't painted, or the lines would have been painted over. So these should be Mees lines, and they certainly occur with chemotherapy, as well as a variety of other chronic problems that come in acute episodes. These are to be distinguished from Muehrcke's lines, which are due to abnormal nail bed vasculature, and all you have to do is push down on the fingernail, and Muehrcke's lines will disappear, whereas the lines described by Dr. Mees will not. And here's Dr. Mees. He's a Dutch clinician, and to my knowledge, he first described these lines in patients being poisoned with arsenic, which is a chronic poisoning commonly administered in acute doses from one spouse to another. This can also be seen in patients with nephrotic syndrome that occurs in episodes, remissions and exacerbations. That's where I've seen it most commonly, but it certainly has been described in cancer chemotherapy. Muehrcke's lines usually don't involve the thumbnail, which in this case was involved. And exactly what the problem is here, I don't know, but they're supposed to disappear if you press upon the nail and push the inflowing blood out of the way. The first paper in the New England Journal involves susceptibility testing for Mycobacterium tuberculosis. This is a problem. It used to be that cultures of MTB took 2 to 6 weeks to appear, and then to show resistance to drugs required sensitivity and susceptibility testing, which involved weeks rather than days. And of course, with the arrival of multi-resistant strains, this kind of time frame is not acceptable for effective treatment. Now, with the development of PCR looking for a specific mutation that's involved in rifampin resistance, matters were markedly improved. But nevertheless, we'd like to have information about resistance to isoniazid, ethambutol, and pyrazinamide at the same time. This was accomplished in this study by sequencing 10,000 isolates across 16 countries, looking for variants that were associated with isoniazid, rifampin, ethambutol, or pyrazinamide resistance. So what was done here is the application of massive parallel sequencing to try to solve the problem of resistance, drug resistance to MTB. So sequencing was done here with technologies that we discussed 1 or 2 weeks ago, as published in a review in the New England Journal. This is now possible and not terribly expensive. If the human genome costs $1,000, MTB genomes are substantially smaller, and the cost is therefore also reduced. Now, so what was done here is to compare Illumina sequencing to standard sensitivity sequencing that requires culture on Lowenstein, Jensen, agar, and then testing against the various drugs shown here, a process that takes probably 2 weeks for interpretation, whereas the sequencing results could be obtained very quickly. Now, This table, unfortunately, the information in this paper is described in a series of tables that are just not very interesting. But basically, we have a gold standard test. That's the bacterial sensitivity and specificity testing with the standard technique compared to the sequencing technique. And we're interested in sensitivity, specificity. Sensitivity is positive in disease. Specificity means negative in health. And positive predictor value, the likelihood that the patient really has it if he's positive, and negative predictor value, the likelihood that the patient who's tested as negative really doesn't have it. So as we can see here, these values, if we look across the various drugs shown here, these values are all pretty respectable, lying above 95% for all of these values. And here the individual drugs are listed, sensitive, partially resistant, completely resistant, etc. And for isoniazid, rifampin, ethambutol, and pyrazinamide. And if we look again at sensitivity, specificity, positive predictor value, and negative predictor value, these data look pretty darn encouraging. And so the conclusion that we can see here is that these isolates could be identified with the genomic methodology with a high degree of precision. And that can be plotted in terms of prevalence of resistance for these various compounds. So if as resistance becomes more prevalent, then the negative predictor value drops somewhat, but it remains very respectable for all of the drugs involved. So this would appear to be a substantial advance. So there are 10,000 isolates tested here, so the numbers seem fairly impressive. And the predictions look to be about 98% correct. And of course, the time frame is substantially improved. And the authors give 3 arguments why they're confident in the techniques involving the knowledge base, the anti-tuberculous drug susceptibility phenotypes that they found, and the genomic variations that they found in the organisms. The comment in the New England Journal is also encouraging, indicating that this kind of technology is going to beat the PCR that's used to identify rifampin resistance, that's also highly associated with isoniazid resistance. That's not bad, but this might be better. And I think what's happening here is the ushering in of a technology that will be soon used for all bacterial infections, even though sensitivity and resistance can be determined with conventional bacteria within 48 hours, but this technology would probably take substantially less time than that. The next topic in the New England Journal is the Myelodysplastic Syndrome. And this is a malignant disease of bone marrow that has an extremely wide spectrum of occurrence. It involves basically, eventually, all cell lines in bone marrow. That means erythrocyte precursors, myeloid cells, lymphoid cells, and platelets. And the clinical spectrum is extremely diverse. What I've shown here is an example of someone with an acquired myelodysplastic syndrome that occurred after Hodgkin's disease therapy. And we can see these bizarre-looking erythrocytes, and here's a neutrophil showing a pseudo-Pelger-Hewitt kind of phenotype. The peripheral smear can be completely unremarkable, although bone marrow examination usually shows the precursors, blasts, etc., that are abnormal in myelodysplastic syndrome. Now, the World Health Organization has subclassified these diseases as a spectrum of diseases, and myelodysplastic syndromes include essential thrombocytopenia, essential thrombocythemia. That means platelet counts above 250,000. These can be chronic. Polycythemia rubra vera, where in essence all cell lines are increased in amount, and the people have hemoglobins above 18 grams per deciliter and elevated platelets and also elevated white counts, etc. Sideroblastic anemias and other syndromes that fall into this disease spectrum. The problem is that some of these conditions are extremely chronic, such as polycythemia rubra vera, and the problem here is not doing these patients any injury. The same is true for essential thrombocythemia, but then there are other forms that progress rapidly and develop into an acute leukemia, which is then obviously lethal. And so the clinicians are faced with the problem: who should have allotransplantation of bone marrow and bone marrow myeloablative therapy, as compared to who should just have increased blood removal or antiplatelet therapy, etc. And these clinical decisions are difficult and could possibly be improved with genomic techniques. And that was done, in a cohort of, I can't see it on my computer, but you can probably see it. It's about 2,500 patients with myeloproliferative disorders. So these patients underwent exome sequencing of 69 genes that are known to be involved with myeloproliferative disorders. And what was found here are lots of mutations. And the authors claim that on the basis of the mutation spectrum that they found in these patients, that they're able to make predictions on what the clinical course of these patients might be, so that decisions could be made about bone marrow transplantation, myeloablative therapies, or doing nothing, doing no harm, etc. Now, 45 JAK2 mutations are known in myeloproliferative disorders. They're common, and we've discussed those already. This gene encodes for a specific kinase that's involved in JAK-STAT signaling. Another common mutation was in the gene that encodes for the protein calreticulin, and another common mutation was in the gene that encodes for a thrombopoietin receptor protein. I don't think it's terribly important that you know these things, but you should get a feel for what's happening in the genomic approach to hematologic malignancies, because myeloproliferative disorders are indeed common, but similar kinds of approaches will soon be used for all hematologic malignancies. So here are the most common mutations here on the left, and then these less common mutations. The scale here is expanded so that you can see these things, but here are all these 69 genes that showed up in at least 5 patients. And of course, some patients have multiple mutations, and I would think in general, the more mutations that are present, the worse the prognosis is. And these kinds of studies require comprehensive mathematical approaches to using Bayesian statistics, which I don't understand, but and models that are constructed. And these models are then compared to the clinical course of the patients, so that models can be developed that subsequently perhaps could be used in a prospective study to predict prognosis. And that's what was done here. Outcomes in myeloproliferative fibrosis. Here's essential thrombocythemia and polycythemia rubra vera. These things are compared on the basis of what mutations are found. You can look at the file for details if this kind of problem interests you. Then pie diagrams are made of the probability testing for trying to figure out how many of these diseases are going to stay within their chronic phase, that is, do nothing, how many of them are going to turn into myelofibrosis, and how many of them are subsequently going to turn into death from acute myelogenous leukemia. And these are predictions made on the basis of Bayesian statistics, and then these predictions in these patients were compared to clinical outcomes. So it looks like models such as these might help in the prediction of outcomes for patients that have malignancies of this particular sort. And I think it's a harbinger of matters to come. And clinicians that are not necessarily involved in treatment of these patients should know what the trend is for this kind of clinical research. The next topic is acute renal failure. And acute renal failure today can be classified by various techniques commonly used as the so-called rifle classifications. Rifle is an acronym for patients that are at risk, patients that have evidence of injury, patients that are slipping into renal failure, patients that have loss of renal mass, and patients that require renal replacement therapy. And this classification is generally made on how much the serum creatinine level has risen within a certain degree of time. I can't memorize these things either, but I suppose if I were still clinically active in nephrology, I would get a feel for this thing. Also important is because creatinine rises relatively slowly, urinary output might be a marker for what's going to happen. So patients that develop oliguria, less than 200 milliliters of urine within 6 hours, or less than 400 within 12 hours, are those patients that are more likely to have an increase in creatinine. The reason all of this is important is because patients that are acutely ill, that develop acute kidney injury, have a high risk of developing high risk of dying or having permanent renal damage that might result in a chronic dialysis state. Now, one of the arguments is when should renal replacement therapy be initiated in patients that develop acute kidney injury? And most people that are involved in intensive care view renal replacement therapy as a methodology in which the evil humors and poisons are taken out of patients, and insist on the initiation of dialysis or hemofiltration or other techniques to be initiated as soon as possible. Others, such as nephrologists, for instance, that have to do these things, unless there's some acute danger to the patient, such as electrolyte disturbances, severe changes in acid-base balance, an intoxication, or signs of uremia, are more inclined to engage in a delayed strategy. In this large study, prospective study from France, this notion was tested, and patients had to be at least within the failure realm of the rifle classification. And these patients were then randomized to an abrupt renal replacement therapy within 12 hours or a more delayed approach waiting 2 days before renal replacement therapy was initiated was employed. And you can see this table here. I can't quite see it on my computer, but what we see in the two groups, the patients seem similar. They're similar in age, the sex, gender distribution was the same, the body mass index was similar. A similar number of patients already had pre-existing chronic renal disease, hypertension, diabetes, congestive heart failure, chronic respiratory failure, and these things that make patients more prone to develop acute renal injury were equally distributed, etc. So the patients were eligible if they were older than 18 years. They had to have a rifle classification at least in the failure range, or a serum creatinine that had increased from baseline levels to a certain degree. And the amount of urine made was also included in this paradigm of selecting these patients. Now, the rifle classification is actually similar to these other classifications, so I would think one would be enough. Can't memorize them all, but other organizations have suggested very similar classifications. I don't see a clinical difference that's important. Now, the only difference in outcomes at 90 days were that the patients that were initiated on early renal replacement therapy had more dialyses than the patients that were in the delayed category. But otherwise, as we see here, there was no difference in survival comparing the early strategy to the delayed strategy. That resulted in the fact that the Oversight Committee terminated this study because of futility. Irrespective of how many patients would be enrolled, the mathematical calculations indicated that there would be no difference in outcomes. Now, I was interested in one outcome here. Hyperkalemia developed in 10 patients with the delayed strategy and in no patient with the early strategy. Whether this hyperkalemia was clinically relevant and exactly how they defined it, I don't know, but that was the only relevant difference that I saw here in any complication or adverse event. So it would appear that by delaying at least several days before initiating renal replacement therapy, no harm would be done. So this could save a substantial amount of money. Renal replacement therapy is also not trivial, and it would appear that the delayed strategy is surely no worse than the more aggressive strategy in terms of renal replacement therapy. Whether or not this study will influence clinical practice, I don't know, but it might. The next paper is interesting and also complicated, as the other papers that we've looked at were. It involves polyomaviruses. And we all have polyomaviruses, and I'm not aware of any healthy person being injured by polyomaviruses. They're named after the initials in the patients that they were discovered. So we deal with BK virus or JC virus. The sequences of these polyomaviruses are practically identical. So we could consider them perhaps one disease etiology. Now, in patients that are immunosuppressed, polyomavirus may become important. And patients that have undergone renal transplant, BK virus nephropathy has been described, where interstitial nephritis occurs and BK virus replication can be documented in urine and on renal biopsy. And if immunosuppression is reduced, then this BK virus nephropathy generally gets better. But much worse than BK virus nephropathy is the development of progressive multifocal leukoencephalopathy. This is a lethal central nervous system disease. It's also caused by polyomavirus, and it occurs, I'm not aware that it's common in patients that have undergone renal transplantation, although here the option of reducing immunosuppression can be exercised. This complication occurs in patients with AIDS and patients with cancer whose chemotherapy should not be reduced because then the cancer would be more lethal, or in certain patients with multiple sclerosis that have been treated with an antibody against an integrin. And that is a substantial problem because progressive multifocal leukoencephalopathy is lethal. So in this particular study, which I thought was very interesting, a treatment approach was developed for patients that develop progressive multifocal leukoencephalopathy. And this treatment is a cell treatment with BK virus specific T cells. And you might ask, what are we talking about here? Is this a gene therapy? And actually it's not. What was done here was that T cells were gathered from a series of donors so that HLA typing would be heterogeneous. And these T cells were then treated with peptide libraries. Peptide libraries that included JC virus peptides that it involves the expression of viral proteins that act as receptors or other things, ST, LT, VP1, VP2, and VP3 proteins. I'm not entirely aware of what these are. The supplement to this paper is 25 pages long, and if you want more details about this, you can load down the supplement. But basically, these T cells from these 30 patients were treated with these peptide libraries, which somehow makes them active against the viral proteins that are JC virus proteins that are listed here. So basically, we have 3 patients that developed this encephalopathy, and the authors picked the best donors that had the best HLA match for these patients, and we can see that the T cells from the donors were pretty good in expressing activity against VP1, VP2, VP3, LT, and ST, these proteins that are expressed by polyomavirus. And here are the MRIs of these patients. You can look at these in detail. Pretty good convincing evidence. The patients all had lumbar punctures. PCR was done to document the presence of BK virus or JC virus in their cerebrospinal fluid, and then they were treated with these cells. And the first thing that we see here is that the cells actually proliferated and persisted in these patients. These were primarily the cells that were active here were CD4 T cells. And the matching for HLA from these 30 donors for these 3 patients was not perfect, but it was pretty good. And indeed, the patients, their cerebrospinal fluid was cleared of virus, and they seemed to clinically improve. And the patients were therefore the basis of this report. Whether or not their survival is going to be influenced, I don't know, but the end result here is that this kind of a T cell specific therapy might offer some hope for this lethal outcome and perhaps for other outcomes as well. Not a gene therapy, but a treatment of T cells with certain peptides that makes them responsive to certain antigen markers on viruses. The next topic is ontology. That's not ontogeny. Ontogeny is an embryological term. Ontology is a philosophical term, and ontology deals with the study of knowledge about being. I thought René Descartes had answered all of this when he concluded, "I think, therefore I am." And therefore he included he must exist. Das Seiende in German. That was just the beginning of ontology, which has developed into a philosophy that I'm certainly no expert in. It involves in the question of existence, the question of the existence of other objects within our environment, the question of the interaction between these objects with one another, and what evidence that we have that these things are real or are a figment of our imagination. That's sort of as I see it. Some ontologists that you may recognize, Martin Heidegger, became famous on this, publishing a book that I don't understand called Being and Time. It's 95% about being, and I wish he would have spent a little more time on time. And Jean-Paul Sartre, Being and Nothingness. In other words, it involves in reality testing, if we so wish it. I wouldn't have thought that this has any application to medicine. I was wrong here because there's a review in the New England Journal called Classification, Ontology, and Precision Medicine. This is going to be wonderful. At least the authors defined ontologies in terms of their ideas about it. Since ontology also includes interaction between certain things that we've decided that they exist, mathematical models can be made of these systems. And the authors state ontologies are systematic representations of knowledge that can be used to integrate and analyze large amounts of heterogeneous data, allowing precise classification of a patient. They actually believe this. And in order to do this, you can look at the old scheme. The way that what we did is taking a history of the patient, taking a family history, examining the patients, making clinical notes, making a few precise laboratory tests. That's what we did. Perhaps doing some diagnostic imaging, perhaps even doing some genetic testing on selected genes that we think might be involved. That is all snowfall from yesterday. What's going to happen now is ontology, and that's going to involve pedigree analysis, data on a bunch of peripheral variables that have to do with health, such as exercise, the wearing of an Apple Watch, biomonitoring. I'm not quite sure what's understood by that, but I believe this is what we call omics, where bodily fluids and cells are examined and everything is sequenced. That will be then expanded to also the microbiome. There are quite a few bacteria in there. Information about the individual's diet, metabolomics, epigenomics, exome and genome sequencing, etc., etc. You've heard all this before, but one of the things that is critical for this kind of study is an electronic medical record system that has all the information on the phenotypes of every individual throughout his entire lifetime. And that is the Achilles heel of this approach, because to my knowledge, I'm not aware of any hospital in Germany that has an electronic health record system that's adequate up to this task. And those in the United States are also extremely heterogeneous, and there's a big debate about what can be done here. But if we don't have the phenotypic data, we can do all the sequencing we want. The chances that anything worthwhile is going to come of it is difficult. Now, the precision medicine crowd has developed a new terminology, and some of that is discussed in this table here that you can look in more details if this topic interests you. Now, again, the Achilles heel is the electronic health record. And most electronic health records, even in the United States, are focused on billing and gathering commercial kind of information, and not really on the phenotypes that the investigators are interested in. Then there has to be a way of categorizing this material that involves ontology, that involves bioinformatics and complicated Bayesian statistics and other analyses to reach conclusion here. And that's what's going on here. So there's a new nomenclature being developed for this sort of stuff, and you can look at this table if you like, then there's an example that's given, and I had to add an extra slide so that people would know what I'm talking about. Fanconi's anemia is a rare genetic disease that results obviously in anemia and aplastic anemia and other phenotypes in these poor involved children that have skeletal phenotypes. They may have microcephaly. They develop early malignancies. Pretty unfortunate situation. Fanconi was a Swiss pediatrician in the first part of the 20th century, became famous on the basis of describing this anemia and also describing proximal renal tubular acidosis with aminoaciduria and phosphaturia, the so-called Fanconi syndrome. But at any rate, it's about Fanconi's anemia. I know that Fanconi's anemia can produce an aplastic anemia. There are 17 genes that have been described that can do this. They're involved in gene repair. The most common is a BRIP1, which encodes for a helicase that's involved in DNA. So in this paradigm, as I understand it, this is a comparison of Fanconi anemia causing aplastic anemia compared to some acquired aplastic anemia from chloramphenicol or something of this nature. I wouldn't think that I would need molecular biology to distinguish those two phenotypes. but that's described here. It has to do with the reactome. Oh my. So this paper goes on describing all of fuzzy matching phenotypic profiles. I think it's all wonderful. So please look at this paper in detail. This is the harbinger of things that are to come, and you heard it here first. The clinical case in the New England Journal involves a 37-year-old man who has the toy as indicated below. That's an AR-15. That's the forerunner of the M16, which is the general U.S. military assault rifle. And as you can see here, he did himself some injury. This is a self-inflicted gunshot wound with an AR-15 semi-automatic rifle. So he has this fairly severe facial injury. And we learn that on the evening at home, he was apparently drinking alcohol and appeared upset. He left the room, and at midnight, and his wife heard a single gunshot. She found the patient slumped forward in a chair in the kitchen, and that was the weapon. So if we look, he shows up he's brought to an emergency room. The first problem is establishing an airway, make sure that circulation works, make sure that volume is replaced, blood replacement, etc. We can look at these values, laboratory values that he's got here, and they're consistent with a gunshot wound to the face. Now, what's impressive is what imaging can do and the reconstruction by imaging of his injury. One eye was completely destroyed, but actually the other pupil worked to light. And his brain is not directly involved. It just merely shattered his face. And with three-dimensional reconstruction, the surgeons are able to determine what they're going to have to do to solve this problem. Of course, the immediate problem is establishing an airway, so a tracheotomy had to be performed so that he could be adequately ventilated, and other ancillary problems were dealt with. The first discussion in the New England Journal has to do with suicide, because this certainly looks like it was in a case of attempted suicide, although the patient, who was later communicative, denied that. But the suicide rates in the United States have increased more than 30% in half of the states between 1999 and 2016. Most of the patients that commit suicide have no prior history of so-called mental illness, although that's not exactly precisely defined here. The lethal means are firearms, so you might think that a preventative mechanism might have to do with reducing the spread of firearms, so that's an important point of discussion, but the clinical problems proceed. What happened on the 24th hospital day? He's been operated on multiple times, and these valiant surgeons are trying to save his face, and they did a very good job. He's standing in the bathroom and suddenly collapses. A resuscitation team is called. They come and resuscitate him with some difficulty, but not very well. And the first differential that comes to mind is pulmonary embolism. Review of the medical record indicated that he had received heparin prophylaxis throughout this entire time. How good it was and how exact it was, we don't know. But the resuscitative team decided not to perform a lysis therapy with actoplaza, and eventually he died and couldn't be resuscitated further despite intravenous epinephrine. We've already found out that probably doesn't help very much, and he was pronounced dead. And at autopsy, what we can see here is evidence of a massive pulmonary embolism. In English, we call these saddle emboli because they involve both branches of the pulmonary artery, and the embolus, instead of breaking apart, hangs there, which contributes to the problem. Not in this case, but what's possible now for resuscitative teams is an ultrasound technique where you can use your iPhone as to see the image, where perhaps this diagnosis could have been made immediately. So that was the discussion. Then here's a case from the New England Journal. It involves a patient who has a spontaneous fracture that's shown here. And this is a fracture of the radius. And I've never seen an X-ray that looked quite like this either. But we see mottled bone reabsorption. It's not really periosteal reabsorption as I would expect from hyperparathyroidism. But what we learn is that his parathyroid hormone levels are extremely elevated. He has actually parathyroid carcinoma. We saw a review on this recently, and that should make up less than 1% of cases. And with excision of this parathyroid carcinoma, we see repair, and this strange mottled appearances of these forearm bones is corrected. And as far as I know, the patient then recovered. Hypercalcemia also went away. A question in the New England Journal involves a patient that has Graves' disease. And the question is, how should this patient be treated? And he has a sinus tachycardia and brisk reflexes. Propranolol alone, I think that might help the tachycardia a little bit, but not much else. Methimazole plus propranolol, propylthiouracil plus propranolol, methimazole alone, or propylthiouracil alone. I don't think propylthiouracil is even available in Germany, but because methimazole is so much better and associated with less complications and less side effects. So the answer is methimazole plus propranolol, and we'll let the Americans stick with propylthiouracil. I wouldn't touch it. Now, the first paper in the Lancet involves lipoprotein small a. This is a lipoprotein that consists of half of an ApoB100 lipoprotein slapped onto another segment that includes crenal repeats, and these crenal repeats are also found in plasminogen. And it's postulated that a lipoprotein small a is a cardiovascular risk factor, perhaps because it interferes with the interferes with the action of plasminogen and makes patients more likely to clot. At any rate, there's a great debate about the risk factor that lipoprotein small a represents, because lipoprotein small a levels are not lowered by statin therapy. And exactly how elevated lipoprotein small a should be dealt with is not entirely clear. So in this large study in the Lancet, what was done here is an analysis of statin studies in which lipoprotein small a had been measured at sequential time points. And statins lower LDL levels, that's obvious. That's how they work. Lower risk for cardiovascular events, but they don't change LP small a levels. So it might be that after statin therapy, the influence of lipoprotein small a could be magnified so that we would have a better idea on judging what the risk is provided by LP small a. So the investigators found a series of old statin studies that we've all reviewed before, where LP small a was measured, involving lovastatin, atorvastatin, rosuvastatin, pravastatin, and simvastatin. And these studies were then analyzed in this analysis. And the LP small a levels were divided into 5 categories, whether they were less than 15 or the quartiles above that, in terms of establishing risk. And if we look at the patients, we can see men and women, cardiovascular risk, diabetes, smoking, blood pressure, LDL concentrations, HDL concentrations, and body mass were representative across all of these studies. Now, here we can look at the risk provided by LP small a. I mean, there are hard endpoints in these studies, so that was good. And we can see that a level below 15 is the lowest level of risk. Those would be low LP small a levels. And baseline and after the effects of on-statin treatment, these risk analyses are enhanced. And if we look at after statin treatment, we can see the risk that's provided by LP small a in an amplified amount compared to the state before statin treatment, because the risk of elevated LDL levels is, of course, reduced by the statins accordingly in the randomized group that got the statin compared to those that didn't. And we can see those effects here. This is a forest analysis, and this result is independent of smoking and blood pressure and LDL cholesterol and body mass index, and that's seen both at baseline and after the statin treatment. And so the added evidence from these 29,000 patients seems to imply that LP small a is indeed a risk factor. Exactly how we're to deal with it, I'm not certain. In Germany, the healthcare system is fairly reluctant allowing plasmapheresis for LP small a levels because, to my knowledge, LP small a can be reduced by no other techniques. The next paper has to do with closed-loop insulin delivery. That would be a complete artificial pancreas as compared to sensor-augmented therapy, where the people wear an iPhone plus a sensor to tell them their blood sugar, but then they have to make up their own minds, or their doctor does, in terms of how their insulin pump is to be handled. And the endpoint was blood sugar control, episodes of hypoglycemia, HbA1c was also measured. And this is here is the device, this is the blood sugar monitor, and this is the pump that's used here, and the sensing apparatus in the group that had this closed loop therapy and compared to open loop therapy. I can't see this table, but you can. And what's shown here is that hypoglycemic episodes were less, hyperglycemic episodes were less, and the reduction in hemoglobin A1c, glycated hemoglobin, was improved. And if we look at these 24-hour examples here, the closed loop is better than open loop, although open loop is a lot better than what's done in the United States, which is still primarily insulin injections in these patients. And here you can see this shift to the right. This sigmoid curve here these are the patients that have 85% ideal control. So the range lies between 50 to 85% in the closed loop patient compared to between 35 and 70% in the augmented sensing group in this study. Adverse events, none of this is statistically significant, and you can examine that at your leisure. So I think that closed-loop insulin therapy, at least for type 1 diabetes, is going to be coming, and the sooner the better. The next study involved ustekinumab, which is an antibody that addresses both IL-12 and IL-23, which are involved in psoriasis and psoriatic arthritis, and also in lupus erythematosus. In this study, patients with lupus erythematosus who received a whole variety of other therapies were randomized to ustekinumab or placebo. And what was done is a scale that's used to assess the activity of lupus erythematosus. 2 individual responder scales were analyzed in this study after 24 weeks. And there were 2 doses of ustekinumab here based on the size of these patients, but it looks like ustekinumab has better scores than placebo, and was better in keeping patients without developing a flare, irrespective of whether they also got interferon therapy or not in a certain subset. So it looks like ustekinumab might be of some value in patients with lupus erythematosus. Then the reviews in Lancet have to do with cesarean sections. To our knowledge, Julius Caesar was not delivered by cesarean section. The evidence indicates that the first European to conduct a successful cesarean section was James Barry, somewhere between 1817 and 1828. Americans claim the record, and Apparently, a doctor in Mason County, Virginia, performed a successful cesarean section on his wife in 1794. This is a life-saving procedure. It certainly was then. But the concern now is that it's been generalized to a degree that I think is rather surprising. I can't see all of this slide, but you probably can. But the amount of C-sections that are performed is increasing by massive amounts, and the reason for that isn't entirely clear. And Latin America is a region where this has become epidemic. 44.3% of births, and no one seems to know why. And a massive increase in cesarean sections between 2000 and 2016, also for reasons that are entirely unclear. And this trend causes healthcare scientists to be concerned, and there's a lot of evidence being expended on why is there such a dramatic increase in cesarean sections. One explanation could be the mothers are fatter, more prone to diabetes, type 2 diabetes, the fetuses are larger, things of this nature. And to measure these kinds of variables is not easy. But we can see the worldwide increase in cesarean sections over time and how this is played out in Eastern Europe compared to Western Europe, where it's somewhat less, compared to North America, where it seems to be leveling off, but a marked increase in East Asia and the Pacific region, and Latin America and the Caribbean. Each dot here represents different countries, and why are cesarean sections so much more common in Guatemala compared to Gambia, or even Bangladesh compared to South Sudan. So that's the basis of this discussion here. Now, in order to try to understand what the reasons for this are, one can employ the Robson Classification system, which looks at nulliparous women, 37th weeks of pregnancy with a singleton pregnancy, if the status of the infant is normal, if they have a uterine scar from a previous cesarean section or not. We can categorize the women into various groups, including group 9, that's all women with a singleton pregnancy with other abnormalities, including a uterine scar, or group 10, who begin labor before 36 weeks. A whole variety of variables are utilized here so that we can try to compare what's the difference in the pregnancies in Guatemala compared to Gambia. And so that's shown here, the trend in China compared to the trend, for instance, in Brazil. And what we see here is the more education the women have, the higher the chance for a cesarean section. And could that be that more educated women are more likely to demand one compared to less educated women? All of this is discussed in this review, and you can look at that on your own. Now, does cesarean section result in more allergy, atopy, asthma, and an altered microbiome in the infants? That's discussed in the second review. And the third review is the possibility of applying interventions to reduce unnecessary cesarean sections in healthy mothers and babies. And so because high use of cesarean section has not shown confirmed benefits, at least not as analyzed in the cohorts presented here, those are key messages. And then there's a nice discussion of education and health professional factors and organizational factors and things of this nature that's shown here. And we'll end with this case report. This is a man in Japan who's enjoying a sushi dinner, and 8 hours later he develops abdominal pain and shows up in an emergency room, and endoscopy is done, and here is the culprit. This is a 15 millimeter long larvae of Anisakis simplex that's penetrating his stomach, and the larvae were removed, resulting in resolution of the patient's symptoms. So anisakiasis is a gastrointestinal infection caused by eating seafood. When the adult worm, this is a nematode, a roundworm, in the host animal dies, then these larvae are released from viscera of the organism to its muscle. And this muscle is then eaten by patients who then suffer from anisakiasis. And if these worms can actually make it through the stomach, they can cause eosinophilia and a host of other problems, but they usually already cause symptoms 8 to 12 hours after ingestion, and then you can have them removed with an endoscope. So that's the first attempt at doing this exercise in English, and in 5 minutes you'll hear the German version. Thank you for your attention.